morning, everybody, and Assalamu alaikum. It's great back again. Hopefully, you guys enjoyed what I did last time. And if you have any questions, I know we didn't have time or we didn't get a chance to talk about the last topic I covered. But if you have any question today, you could ask me. And today, my name is Mustefa. I'm from MD Anderson, Houston, Texas. We're going to talk about image matching, cover, head and neck. Last week was great. Last week the presenter, they did a great job. I was listening, and I mean, they cover all the rules and all the tricks. But what I'm gonna do is, I'm just probably I'm going to repeat myself what they said the other day, and probably I'm gonna add some more today. Even though they cover different body parts, I mean, the fundamental is the same. So let's begin. I hope everybody can hear me. Contents today, even though I was covering, image matching, and we're going to troubleshoot the images. Some of the images we're going to talk about, how we're going to fix and stuff. But I put ALARA first because, to me, the principle of ALARA gave me an understanding of every photon's count to the point that principle, if you don't have to take any film, unless it's necessary, you don't do it. That principle, usually use it during diagnostic imaging, but I think sometimes the fallacy of the concept of KV versus MV is because we're given a high dose of MV, talking about, for example, you got like 70, gray, when you give that one, sometimes we forget that even those KV doses, you're going to be patient with those for life. So I want to talk about ALARA first. And the ALARA actually going to help you to set up the patient perfect and to make sure that you get your image, the perfect image the first time. I'm talking about that first, then I'm going to talk about image matching, then we'll go and talk about how we're going to fix images. All right, here we go. So ALARA stuff, the principle stuff, like I said, even in small dose, unless you need it, don't give it. For those who've been to diagnostic imaging, we collimate. When we take, you can see the name here, and the fingers, we collimate to make sure, first of all, give us a crisp image because, we reducing the scatter radiation. At the same time, we are reducing the area that we expose to radiation. And plus, when we x-ray people, we use apron. We give them apron, the lead apron, and we have this for thyroid. We do that. So imagine we probably see this patient like once every 6 months, or maybe like a year. The patient, they come and they do not have chest X-ray. You do that, but you cover them. You cover the thyroid. But imagine now, imagine people every day. We need to have that. That technology is the best thing happen to, treatment, radiation therapy, especially, the advent of KV imaging. We get to see our image clearly, but we still have to be responsible. We cannot be like hiding behind the MV and forget about the KV because it's going to be the dose. And we know that one thing we know about radiation, any kind of dose, CT, X-ray, it's damaged DNA, and that creates mutation that would, create different kind of diseases. So we need to keep that in mind, knowing that in our head, thinking about it every time when I press, take X-ray, knowing that this could damage the DNA of my patient laying down. That should give me pause, a break. Pull back a little bit. I said, okay, I need to get this perfect. I need to get this image the first time. So that's how it comes, to a point of positioning patient the right way. Another thing you could do is, for example, I have a brain here, KV. A default technique on the machine is 70 and the mass is 5. The KV is 70 and the mass is 5. But look at it, that image it's good. You can see everything. And we know diagnostic things here. What we do, we just match it. And you can see that bony anatomy that we need here. But look at this image was taken with 65 kV and 2.5 mass. Just look at the mass. Most of the dose come from the mass. So we just have that mass. Think about it. If you have to repeat the X-ray, you use it. If you use the original default, that's going to be 4 times. But so that's what we need to do. Brain, think about a brain. It's all air, so we don't need much mass, to get a good image out of that. The same thing with lung, it's air, full of air. So use the anatomy, the knowledge you have in the anatomy, that's what we need to use. So it's a good image, with 2.5 mass. Another thing, again, brain here, and we also have an AP. What we could do is we could alternate our orthogonal angles. You got 270 degree, you got 90, and you have a 0. But you could also add 180. The reason I'm talking about is we all know that entry dose is much, much, much more than exit dose. The entry dose usually is like 6 to 7 times exit dose. So by alternating, by rotating the AP versus PA, the right lateral versus left lateral, we reduce those to the certain organ. For example, right here, the eye is going to get some dose. So by flipping that, by using the PA instead of AP, we could spare those. The total dose will be less. So think about that. I mean, as long as the clinic participate in, the radiation oncologist and everybody's agree with that, physics, everybody agree with that. I think that's a good idea to alternate AP versus PA and right lateral versus left lateral. Again, a lateral. Based every day when you have patient, when we have patient in the room, when we put them in the room, when I think about taking a daily KV, I need to make sure that a lateral is behind my brain. Another is collimation. Collimation is, first of all, it's going to give you, especially patients very, very big, unless you collimate, you hardly see stuff. It's going to be blurry, or it's going to be grainy, or it could be like, all white. So either you're going to have issues with, with penetration, which is from the KV, and the grainy comes from the mass. But if you collimate, usually when you do the AP or your PA, you're going to see where you are. It's going to show you exactly where you are. On this one, all you need is the depth. You could use it for, in and out too. You could still see you in and out, with the ISO. But if you collimate like this, we have a crisp image and we reduce the area we irradiate. Here's another one. You can see the image right here. The image you see on your right side is a good image. You can see the ribs, you can count everything. But on the one on the left side, it's overexposed. Here I'm talking about overexposure, X-ray versus CT. See, on the X-ray, we'll be able to see our overexposure. But on a CT, it doesn't matter how much dose you give to that image. There's an algorithm built inside the CT that will fix it and still give you a good image. So we don't even know that image is overexposed, and we know how much dose that CT gives to our patient. So we need to make sure that before we X-ray or before we scan, make sure that look at the side of the patient and make sure that I will be able to cut down the mass. Usually this happens at the simulation when it's coming or CT. These are examples. This is like a mini scan, or we call it a localization scan. When you have, if you do stereotactic, sometimes you want to identify the tumor instead of like just putting your BBs before you scan. On this one, you can see right here the lesion on the spine. The default setup for this was 120 kV and 400 mass, but we'll be able to get a good image to identify. You see, diagnosing right here. To identify, this is a good image, to identify the tumor where we're going to place our ISO with half of the mass, 200. 200, think about it. Even if you make this mass 800, it's still going to show you a good image, so you don't know you overexpose your patient. On the CT, we need to understand that algorithm exists in CT that never tell us whether we have the image, whether image is overexposure or not. All right, here I have different technique for CBCT. Now look at the head, use the full fan, and the KV, the KV here is 100 and the mass is 150. If you do this is spotlight, the CBCT, this is what it does is it will give you the image you need. It's like just like the head, it's a partial arc. It's not a full arc, but it gives you, you reduce the technique again here, 750. It's more than the head, but let's say, the head doesn't work for you. One thing about the head has 25 cm diameter of reconstruction, the image. 25 cm is big enough for a child. For a pediatric patient, you could do the abdomen, the pelvis, the thorax of a pediatric patient. And if everybody agrees that, you'll be able to see, the tumor by partial arc. Does everybody agree with that? Think about it, how much you're reducing the dose here, 100, 150. But I came here on the pelvis. Just look at the dose. KV, 125, but look at the mass. Always call, I want you to be aware of your mass. That's most of those comes from. 1080, 1080. That's a lot of mass. Now, you have a patient on the table, you set him up, then we go out and we take the CBCT and we looked at it, it doesn't look good, doesn't line up. If you repeat that CBCT exam, it's going to be 2,160. However, if you do a KV, either AP or PA image, which is only takes 75 kV and 5 mass, look at how beautiful this image is with this technique. You do that first, make sure your patient is straight. Some patients are easy to set up, but if you know that your patient is very challenging to set up, take the AP first. Get them straight, because instead of repeating 125 kV versus 1080 mass, just take a 75 kV with 5 mass image and make it easier for you. First of all, it's going to be fast for you, because instead of repeating a CBCT, how long it take to do KV? What, 20 seconds? So you do that, and we'll have a good image instead of like repeating CBCT. When it comes to CBCT, make sure you get it the first time. Like I said, I'm putting this doses because we want to be aware. Back in days when we take X-ray using cassette or films, first we have to go in the room, put the film holder to make sure that we align. We make sure the patient is perfect aligned, because I've taken those X-ray you have in the AP and the lateral. Then you take that one and process in the cassette, in the processor. That will take sometimes like 5 to 7 minutes. But a place like, big institution like MD Anderson, when you have so many machines, imagine if other machine also processing the film. You may end up probably standing there for 10 minutes. Patient is laying down, probably a prostate patient with a full bladder. Patient is cold, freezing and stuff like that. So because of that, back in days, we make sure that we set up our patient perfect. The first time, then we looked at it, we use the DRR to tell us out. If the patient is crooked on the DRR, you don't want to set them up straight, because you're gonna have a hard time. Look at your DRR, use it as a guide. Look at how the patient is laying down. Then if the patient look crooked, after you set them up, just make them look, it don't look like the DRR. So what I'm trying to say is, because of this, back in days when we used to take 7 to 10 minutes, we make sure that we get them straight the first time, we take our image. But now is because we'll be able to get the image in 20 seconds. Sometimes what happens is, we forget the principle, the basic principle of positioning, making them like perfect, the way they were sent. So let's keep that in mind. But like I said, it's a good image with the very, very low dose versus a CBCT. So, choose what works for you. When we look at, patient is too small, you need to reduce our, we need to reduce our dose. And last week we talked about, those imaging wedge of side that we use. The first one we use for the head and neck, and here is the half fan for the rest of the body. You could do abdomen, pelvis, all, and he's inside the machine, and he is no fan. Remember last week the president said that even if you don't have a fan, there won't be an interlock. The machine is going to work. But imagine if you don't have interlock here, we are giving patient a lot of dose, because there's no filter in here. First of all, you're going to have a bad image, especially if it's like a small image like head and neck and stuff like that. It's going to be too much scatter in there. Second, we are giving them too much dose. So let's keep that in mind too. We're gonna have a better dose, and if you have head and neck or brain, use the full one. It's gonna give you a good dose. I mean a good image. All right, so we're going to start now with our demonstration here, image matching. And make sure some of the video may have some sound, but I'll stop it if it starts. I'm new today, we'll talk about that. Right side lesion, our DRR right now. Both pairs are on the screen. To the AP, it's rotating by now. Right now, going to the lateral side. So we go superimposed right here, and you can see that, based on the color, they're not aligned. If you look at it, the spinous process are off on the AP, and you can see that the space between the vertebrae and also they're off. So, let me stop right here. One thing I want to talk about is if you imaging thorax, make sure that you show either the T1 or T12, because we don't know. I mean, if you don't have any starting point where we start, we don't even know which spine, which vertebrae we are. So make sure that usually most of the mistakes made when we image when there is vertebrae involved. So either show T1 or T12. So in this one, it's a good image because the traps are showing the T1. I mean, it's a high ISO too that helps, but sometimes you have an ISO that very low, and you might be able to see either T1 or T12. So try to move the image and imager, and it'll be good. So waiting to take we take the lateral down to rotating at this point. You can see that spine. So anybody has a question here or anybody else? But one more thing I want to, sorry, I said at the beginning, I want this to be interactive. I want everybody to get involved. Anybody have a suggestion? Anybody could say, why are we doing that? So feel free to open your mic. And the one more thing I want to talk about, we have some images that are provided by the clinic, like Ghana. So when we get to that point, I would love, participants from the clinic, to explain the video. When I get to that point, I'll let you know which video I'm talking about. Please, Ghana, I'm going to call on you. Be ready. Thank you. So next one, this one is only one image instead of pair earlier. We're just doing the AP right now. And you have an option to do, it depends what machine you have too. So some people prefer to do the APC right now. If you can see, let me stop right here. You should not be able to see T1 on this one. I mean, you can see the clavicle, the head and stuff like that, but that's not a good practice. Let's make sure that we show from the top that we see, it just cover it. We don't know, we're just going to start here right now. I mean, this one is pretty close to be able to tell. Sometimes you may come like right here, and you don't be able to tell like which spine is. So let's continue and let's see what, again, but it's off. Anybody wants to say suggestion, anytime you can open the mic and say how we're going to fix this. If not, I'm just going to keep playing this. Here we go. You see now how in and out is moved. You see, I go back right here for a second. That was off, and then now right now, you can just see the space right here. You see now, I moved the there for the imagery. You can see that. So like I said, trying to get a T1. See, this is good now. At least before we send our image, we make sure that we get the top. We show our T1, so the doctor doesn't have to get confused before approves the images. So let's have the practice to make sure that we get our T1 or T12. And now you can see that now we're going to lateral. So we saw in and out was good, left to right was good. Here, the only thing we look at is our depth. And let me play it again. But sometimes you have a patient who's not like, kind of off like a couple of millimeters. Maybe you look at your lateral versus the AP and try to split it. Could be some kind of rotation that affects that. Sometimes these videos get stuck. But now I need somebody to open their mic and tell me how we're going to fix this. Anybody? Let me go back again and start from the beginning. So let's see, it could go slow. Okay. Let's see, I'm halfway right now. The question, anybody? Feel free to open your mic. All right, so let's play this again. Let me go back one more time so we can show. All right, here's the DRR. Okay, now you daily. DRR. Daily. All right, I'm gonna stop it right here. This is a DRR from simulation. You can see that the patient is crooked. That's what I say. Let the DRR guide you on a daily setup, because If you have them on table straight, the patient's gonna be off. So the criteria are when you have the patient on table, set them up, look at them, they just make that a little crookedness. But the only problem is with crookedness is if the patient is straight from the beginning, from the simulation, it's easy to do straight. But to make them crooked, kind of tricky sometimes. So here's our chance to make sure that we get them straight at the simulation, because everything is based on simulation. I know they spend like an hour, 45 minutes simulation, but the next 10 to 30 days is going to be, it's kind of set up. And it's going to be difficult for the therapist, to match this. For example, you set up, you have a thoracic patient or abdomen, you made the cradle, patient arm up, you made the cradle, you come out, patient is crooked like this. And you went there and you move the patient. The problem, if you don't reform your cradle after you make them straight, if you do your cradle again, you move them, first of all, they're uncomfortable because you're moving them in a cradle that was fitted perfect earlier. So my suggestion always is go there, deflate your cradle a little bit, put some air in, make sure you fill all the gap, get them straight, then scan. Take time. It's a matter of 5 minutes. It's like, let's take time because it's going to be the next 6 weeks of their time. And again, we are responsible for their be laying down perfect. Like I said the last lecture, they trust us. We're responsible to give that trust back. Stop the line. I hope you remember to stop the line. Always make sure that to give perfection. This radiation dose, high dose we're given, we better hit that tumor. So let's go back here. I'm sorry, I'm getting off the topic, but I'm just going through brainstorm to make your life easy, to make your work easier, because we together with the patient. All right. So it's around T12, you can see that, and then we have the sliding window close to 6 millimeter, 0.61 cm. So one on top of the other, because if you go left or to right, it's going to show you either the DRR or the daily. All right, let's play this. So you move the patient a little bit, and that fixed that. Let's see again. So the DRR will come that way. So you move the patient to the left, to the patient left, and that fixed it. But like I said, here we go here. All right, let me just go. All right, here we go. This is given to us. This is the image I was telling you that we got from Ghana. And anybody from the clinic there, you could open your mic. Anybody? KBTH clinic from there? I hope my could hear anybody. I'm not hearing anybody here. All right, so I continue. And you can see that the displaying window will show you, but that's another tool you can use. Either you can use the displaying window or the moving window, sliding window. So that's one thing you want to see. That will give you the patient is chins up, chin down if you need it. Probably will give you that. All kind of tool earlier. You saw that on that thoracic. Patients going back and forth between the primary and the secondary. Primary being the simulation, the DRR. The secondary, the one the daily. But here they're using the spring window here. Anyway, anytime you could participate, anybody from KBTH, thank you. Thank you for everybody who provided videos, images to us. Thank you so much. All right, so that's another tool you use. You look at it, superimpose it, like the split window will show you exactly how you could move. It's a little. It's not bad, but a little bit there on orbit. Sometimes we don't have to stress out. But that's knowing our patient, how they set up. The patient diagnosis could set up perfect for you, but sometimes you may be off like a couple of millimeter stuff. The question is like you've seen the image, the doctor likes it, just move on because you don't want to keep them on team for a long time. But again, always go for the best image you want to get. All right, let's see another one here. Anybody want to try this? Anybody from KBTH? Okay, the head and neck here. Let me go back again here. Let's replay this. That's perfect move right there. You can check the chin right here. Good. Because the shoulder, clavicle. I mean, clavicle is a move over, but you know what? If the patient seemed perfect, you could able to get the clavicle right too. But you don't want to depend too much on that one. But sometimes, patient shoulder goes down. That's why clavicle is not aligned. So make sure that you're facing the mask properly. Push it back here. This is the MV image. One thing about not only that, when it comes to MV, make sure you check your field too. Not only the patient aligned, make sure your field is perfect. And there, within the tolerance that the clinic, some clinic may have a 1 millimeter, 2 millimeters. So I'll play it again. All right, this is for clinic again, burn tank, NLCC, and anybody from there, they could participate again. Let me play this. You can see that the AP. Anybody want to participate? Okay. And the lateral right here. I like that, the collimator here, so you don't have to give unnecessary dose. You can see that going back and forth. You're going from the primary to secondary, which is primary is your DRR, secondary is the daily. And looking at the spine right there and the space, it's good, and the lateral, you can use your spine for in and out, make it easier sometimes. If the bone looks good, you have a tool, this is the new technology. We've got all kinds of tools, you have standing window, split window, you can go back and forth. So use any tools, good for you. Because superimpose pretty good here. When you move that window, you can see that the spine is superimposed. Showing. We'll go a little faster. Let me skip it here. Checking on the bone. All right, now we're back to AP. It's pretty good film here. You can see that, how aligned that is. You can move your window again to see, look at that. And sometimes you may even, if you want to come and open this a little bit right here, you can see your spinous processes, but we'll be able to see partial of the spinous processes. That's a good thing to show you whether the patient's crooked, patient's straight, patient's aligned. Use that on AP or PA. This is a good one. Even look at the clavicle, they just like perfectly aligned. So that's our goal, that's our goal. Make sure that we align our patient perfectly. Again, you have your DRRs right here. We're taking the lateral. We got a contour here, but usually I take off the contour, make it easier for us to view the image. I change the contrast, to whatever you want. Like that's automation. If you do automation, make sure you go back and check. Don't depend on that one. Maybe it could get you closer to what you want to see. But then you got that sliding window. You could open as much as you want. Looking at that, again, this is a good image because it still shows the T1. Bring that, make sure that you could show that. So there's no confusion what level of vertebrae spine we are. First, brush your skin on this one, then you can put a speed, There's no rushing, here. First thing you want to make sure that the patient on the table get the best care. Like I said last time, it doesn't matter we're behind or not. That's not the patient's fault that we fall behind. That's not the patient's fault that nobody, people showed up late to work. But we take our time, make sure that we get our image and treat them. Okay. All right, here we go. So we got the photo. Now, right now we need troubleshoot. So hopefully this time everybody get involved. Sorry about that. I think I'm that excited, feeling that you guys want to participate. Okay, here we go. Okay, make sure that I have. All right, I'm gonna play this. All right, somebody, I need someone to talk about this image, please. I need someone say something. Open your mic. I want to participate. Let me see. I see some chat. Somebody chatting on this one. All right. Please, somebody participate on this. I'm gonna play it again.
Hi, Mustefa. I think the participants aren't able to turn on their mics unless I allow them to. So if any of the participants want to talk, feel free to raise your hand and I can allow you to talk.
Thank you. That'd be great. Yeah, so for this one, you go ahead.
Hello, sir.
What this, man?
The neck of the MV image is not raised up enough,
Okay.
whereas the CT scan image is higher. There's a little bit of rotation there.
Okay. Okay. So to fix it, what do you want to do to the patient? How are we going to fix this? I'm going to play it again.
We can.
So like you said, this is a CT scan image, which is the DRR. I'm going to stop right here. Okay, that's a CT scan image, which is the DRR. Now I'm going to play it to show our daily. All right, that's our daily. DRR.
Yes, yes.
Okay, so what do you think is happening right now? What do you think is happening?
There's rotation. There's rotation. The chin of the CT are not balanced.
Exactly, exactly. So which way do you, let me go back. See. Yeah, okay. So which way do you think the chin needs to move?
The chin need to move down.
That's right. Chin needs to move down. Yeah, chin need. So I'm gonna go back and play this, bring it back to the beginning. All right, that's our daily. You see how that, play that again. Yeah, chin needs to come down. That's the best thing, you know, cross better when it comes to chin up or down. Thank you, sir.
Thank you, sir.
Right now, checking all lighting window. I mean, everything is good now. Check, I mean, the spines are pretty good. Base of skull was good. Spinous process, I mean, it's been perfect. I want you to look here. This is where the issue is at. Okay, look hard right there. Anybody interested to jump in there? Raise your hand.
Hello. Yes, my name is Vincent.
It's Vincent. How you doing?
Yes,
man?
I think the issue with the knee is about the mouth bite.
Okay.
So if you look at the difference between the lower jaw and the upper jaw, there's a slight difference in the gap. So it means the kind of mouth bite that was used maybe during treatment and the one that was used during simulation, there is a difference. So that's why you see the gap in between. One is wider, the other is a little bit.
Based on what you see, how can you fix this gap right now? Is there any way to fix it? Like, because I mean, for example, let's say they use now, backlock, and you still have this kind of open, let's say, they use or not. But how can you fix right here? So I'm gonna go back again to the end and let me bring this. I'm looking at this a little more close. Yes, sir.
Abraham.
Yeah, Abraham. Yeah, talk to me, man.
You will see that the number of the cervical is less compared to the number of cervical vertebra in the CT simulation.
The number of C-spine is less.
We have maybe the headrest. Them say the headrest that was used.
Yeah.
The headrest that was used in CT is a bit higher than that of the
high. Our spine have been off, but the spine is pretty good right here. You see it? You see our spine is aligned very well, and the spinous process is good. Even the base of skull is aligned perfect. Our issue is like by the chin right here. So I think what's going on is the patient needs to open his mouth a little bit. Just when you look at it, now let's come right here. I'm gonna come straight to it. Okay, look at here. See how close that is? You can see you see how open that is right here. So it depends what we treat, but this is what the issue is on this one. Thank you everybody on this one. Let's go to the next one. Thank you, Mr. Abraham, Mr. Vincent. I'm gonna go to the next one.
Yeah, fine. So the difference in between the penumbra on this image I'm seeing right on the screen different from the other one or the other image I saw.
Okay, so the penumbra. So you decided the penumbra from the KV. Are you looking at from the point of right now the image? So what do we use what we're looking right now is what do we use like to match? Unless sometimes we do CBCT for soft tissue, maybe CBCT, and they're not perfect because you're the one who see them every day. Because the patient is set up perfect. So you mentioned that to me. I'm glad you said that. You reminded me. talk about that. So discuss with the doctor whether you use daily KV versus daily CBCT, unless it's necessary. Soft tissue, you don't have any option. But all right, sorry, go ahead, my man. So I see point, but on that one, the patient mouth is a little open, so I need to be open, like very subtle changing. But this one, you can see on this one. Yeah, but what do you see? Okay, now I'm talking about when it comes to the setup, like, I'm talking about how you're going to set up. Let's see, and again, I want you to look at the mouth, okay? Look at the mouth.
The mouth, okay.
Look at the mouth. You see the mouth? What do you see on the mouth? What's the difference between the
I think my other colleague mentioned about the bite block. The other one, the bite block was the quantity of the bite block is more than the quantity of.
Does the patient has a bite block right here? Do you see a bite block on this one?
No.
Okay, so you don't have a bite block here, but what do you see the difference like between the DRR and the daily image? What do you see on that area? Again, I'm looking.
Yes, I think on the DRR the mouth is closed, and no, on the DRR the mouth is closed, and now on the port image it's a little bit open.
Yeah, that's how you're going to fix it. Yeah, that's what it is. One mouth open. So just go to the eyes, set up for the eyes, look at everything looks good, and then look at the whole picture. That's what it is. Sometimes we concentrate on our ISO and we tend to forget stuff. We like, ISO looks good. Why is that patient rotated? Yeah, let's look at everything participate, especially on head and neck. Check it. Let's check like the mouth. So on this one, yeah, exactly. Thank you. Yeah, the mouth need to be closed on this one. Open. Yeah, talk to me.
This is Akab from Pakistan. Walaikum assalam. Actually, I observed that in both the images, no doubt that lower mandible is slightly different, or it's slightly open, but there is also problem in the base of skull. It's also moving when we are matching the DRR and the imaging. So yes, I think the placement of the patient on the neck rest is also a little bit issue in both the images.
Yeah, I could go back while you. Let me go back to the image. Okay, so let's see what you're talking about, my man. How does it go? I'm gonna go back here. Which one do you want me to play? You want me to play this one or the one before?
Yeah, this one. This one is okay. Yeah, it's a good image.
So, all right, talk to me now, man. Is it playing?
The other colleagues actually also mentioning the opening of the mouth or the lower mandible. We can see actually over here, but also see the base of skull. It's slightly moving. Yeah. It means that the patient head is rotating. There is a rotation from.
Yeah, once we don't have a post image in this, but you're right. I see that the meant on that business call, and thank you for mentioning that. So we're concentrating on the mouth. Thank you. All right, we go to the next one. All right, let's see here. All right. I just put a picture of this. On this one is just a bite-block. Usually, no, this is a stunt actually. This one, the patient goes to the dental here, and they get measured. So one thing about keeps the tongue, in the same position, and plus, the problem that we have open mouth and closed mouth, that will solve this one. Bite-block, we have a bite-block right here on the mask. These guys have a bite-block, but this one is stunned. I just put that just to show that maybe, many clinics probably haven't started yet, but this is what we use to make sure that, if you have this, they're not going to open their mouths. They're going to be in the same position. So that will solve the issue. And the two brothers spoke about the mouthpiece. This is what's going on. For those of you who haven't seen one. All right, let's go here. The video delays the cam. All right, so this image doesn't look bad at all when you look at it, a little bit, but you still see, but you cannot tell what's going on in this. I'm like, sometimes you look at it, what can I do here? Then that's why you want to take both pair. You want to take you lateral and you want to take you AP. You want to do that. So let's go to our AP. So again, let me play this. It's kind of sometimes tricky to tell. I said, okay, that's why sometimes say, okay, let's take our AP. Let's take our AP. Let's see what's going on. All right, let's go to AP. Let's move slowly. Let's see here. All right, there we go. AP. These are AP. You see, we won't be able to see that on the laterals. Anybody could participate. Anybody, anybody wants to raise your hand and jump in it.
Yes, I can see that there is we can see the difference. There is a significant tilt in the head. It's from the bony structure is, we can also see the difference in the lower mandible, but yes, we can know that the lower mandible is not a reliable structure. So we need to actually focus on the
Yeah, sure. So if let me stop right here. See, let me stop half. Let me play this because I want to stop it on the 50%. Here we go. I stop it on the 50%. You see, on the 50%, I stop it. Look at the spinous process. They're not aligned. You see, there's a link part. Probably about 3-4 millimeter, more than that actually. They're not aligned. You see, now when I move, when I play, you can see the difference. You see the spinous process right here. This again. So my battery is tripping, but I'm gonna play it again while I'm connecting my computer. I want you guys to look at it, okay? Yeah, so you see the DRR is spinous process right here, and you daily spinous process right here. So again, earlier I was talking about, look at the head even, the head tilt. It's very hard to reproduce a crooked patient. That's why we want to make sure that during simulation, we get, sometimes, it could be the lesion, you don't be able to get it. Let's say if there's like a big lesion here on the head, you cannot make you don't have any choice. Especially if they have like some kind of surgery, you cannot get them straight. That's understandable. But if patient is like, walking, talking, everything and stuff, perfect, let's make a good mask to make sure that, they set up perfect. So on this one, you can see the patient is all to, because spinous process now. See what spinous process is on this one. This is, and here's the DRR. So look at, let the spinous process guide you. So move the shoulder this way and check after that. It's not only the issue, sometimes, but solve the major issue. And when you do that, have a point, have like, a starting point. Alanda, look at your film, just see which one sets up perfect. Then start from there, and whatever is off, you can either you move them to the right or the left. That's the easiest way to do. And good thing is, septum is good here. Septum is here, so always remember to put your septum when you do your head and neck images. It will guide you. Septum will guide you, so you will be able to see. Even though, let me see, for you left to your right, you can fix that. If it's high ISO, but if you treat in low, so it always depends on what we treat. Sorry, we got corrected. You can see a spinous process, they align, but there too. It's almost there, like within less than millimeter. One thing I want to mention, sometimes what happens is patients lose weight, and especially if you use, some setup that, or if you're using clarity, maybe, get some patient lose weight, and, you have, if you can see here, the basal off, and you can see that, sometimes there's extension and what you call it, neck will be extended sometimes, and sometimes will be flexed, and sometimes it's going out of control, patient lose weight. That's why we tell usually patient, make sure not to lose weight, to maintain their weights. So, we can set them up. Always look at, there's a big change maybe you need to do, which adaptive simulation, just to see what. Or sometimes, there are days like we have to make a new mask, new setup for the patient. On this neck being straight. Sometimes, even you need to take the mask off, but here the neck becomes a little anterior, so you check that the patient is on all the way to the top, or their head. The neck, I'm sorry. So these are like, these are one of the, sometimes, like I said, you need to take off, let the patient sit up and let them down. And before you leave the room, ask the patient that, are you okay? For make sure that they set up. Sometimes patient doesn't, they don't want to talk. They just want to think that like, they're messing up the treatment by talking. So have that open communication. Have they laying down perfect? Is it different from yesterday? So in this one, and you can look at an AP, going back and forth, kind of thing, Feel free to jump in. Anybody wants to treat patient to have more than one therapist, the minimum of 2, because sometimes our eyes get tired. And whatever I don't see, maybe my partner, if you have to take off the mask and position them again, that's what we have to do. See like how all that spine is. Got a big difference in there now. So those are the rejected ones. So now we go to the point that AP right now. All right, now see approved one, the rotation, but that's not bad. It's our guide us, our spinous process and vertebrae.
Yes, I think there is a slight difference because if I look at the superior displacement, if you look at the clavicle,
That's true.
and also if you look at the spine. So in one way, either there is a use of the wrong headrest, or the patient was struggling to stay in the position. So that's why it looks like he has tried to lift the chest up, and maybe either the patient was uncomfortable. Yeah.
That's why, we want to make sure that our patients are comfortable because, with the stent and by block, for either 15 and 20 minutes or half an hour, it's not easy. So we make sure that at the simulation, we get them perfect. And once we get them perfect at simulation, they can stay still, so they don't move. And like I said earlier, there's a lot of factors, from losing weight and maybe the patient all the way to the top, before we put on. Make sure that, and even though, like I said, with the, sometimes patient the clavicle push it back, make sure that just like doing the simulation and give them something to hold on, they be comfortable, if they hold on at the bottom or to any part, if they hold that so they be comfortable, I mean, yeah, those are those are the other, issues with the address. That's why, like, always have always have more than one therapist in there. I looked at it, I said, oh, this looks good to me. Maybe we looked at it, I said, no, Mustefa, let's stop here. How about we take this, can we fix this stuff? So always have participation, from our core. What do we see here? Anybody? Like I said, sometimes when you see something, kind of good idea, sometimes when you fix it. So on this one, anybody want to participate on this one? All right, so I can tell you when we get to the AP, look at your spinous process right here. Look at the step, you can look at it, so, and you band them too. So look at that picture right here. Yeah, that's when the AP was rejected, right here. And you can see that they're going to go to the approved film. But, this is like, look at the whole picture. Sometimes, we have the CBCT here at the end of that needed. Like I said, much of this location, and like I said, for the thoracic, make sure you get your Ghana, everybody here, Alfred, George, everybody, and any questions.
I see some people raising their hands have questions. If they go ahead and chat.
Yeah, okay. My question is that in all the images we have seen that that there is an option to delineate the bony structures on the DRR. Is it to provide us a quick reference to match the portal image with the DRR?
Again, there's an option.
So there is an option to delineate the bony structure, means outline those some bony structures, and that can appear on the DRR while you are matching your DRR with the portal. Is that provides a good quick check or a quick match instead of just matching the DRR with the image with different tools?
I mean, at the end, man, you have to make sure that you you use your DRR to match at the end. But you can use all these tools, to get what you want to get. Like I said, some people choose. I mean, especially right now, the new TrueBeam, new Versatile Electa, they give me all kind of new tools. But at the end of the day, you got to go back to the basic. Make sure you might, look at the end, after you finish, I said, okay, let me go back to the basic of imaging. What my DRR looks like in my daily. You have all kind of options. Yeah, thank you for that question. Yeah, that makes sense. I mean, there's a lot of options. I'm telling you, there's a lot of change since I started doing radiation therapy, and it's for better. And that should make us responsible because this time we'll be, like I said, it may take 20 seconds for us to do imaging, but like I said, it doesn't replace position. We should position them right, and but use any tool that is easier for you. And go back to DRR.
Thank you.
Thank you.
Let's go back to the slide before the acknowledgement. The slide before acknowledgement.
Yes, sir. We go to the
your slide before acknowledgement.
Yes, sir. I'm going right there, boss. Okay.
Now, you said for the last sentence, always finish with looking at the big view to make sure you match correctly. Can you please expatiate the last sentence? The last sentence, please.
Oh yeah, you match correctly. I mean, the big. See, what I'm saying is, after the setup, like for example, let's say we are treating, let's say, base of a skull, okay, and we put our ISO, we looked at our ISO, it looks good and stuff like that. But sometimes, if you hang on just on the ISO, you may miss the big picture that you make sure that the rest of the body part close to that is matched correctly. For example, it's high, and you have, the eyes, you have the optic nerves, you have the optic chiasm and stuff like that. Not only think about the target, think about the OR too. Organ at risk, because by looking at the whole picture, you got like, by looking at the whole picture, you could protect your OR too at the same time. That's what I'm trying to say. Look at the whole picture. I mean, our goal is for us to get to our ISO, make sure our target, we're given bony anatomy. I mean, on a KV, you'll be able to see all that stuff, unless you have a CT, CBCT to see all this, OR or full soft tissue, GTV, PTV. But even with that KV, once you align up to your ISO, look at the whole picture.
Hello, sir.
Yes, sir.
Sometimes the medical physics is what you normally get on the portal image. I don't know whether you get my question.
Yeah, I get it. No, see, I think I see your point. But you know what? Hopefully there's some physicists listening to this, or the symmetry, or make sure we need to provide the full image. You're right. Sometimes you have an image and you don't even see it. Maybe you don't even have a joint to starting point. So we need to have an image that give us like a good view of our AP or lateral. If it's too small, it's going to be very hard for us, as a therapist. Watch that. Is that what you're talking about? So it's very, very important we have enough image that we can see. If it's thoracic, at least give us T1 or T12 based on what the ISO is. And if it is a joint, give us, extremity, give us one joint so we can start point. Very, very important. If there is any spine, it should be, if it's like pelvis area, they have area crust. Something that we have a starting point.
If no one else has a question they wanted to ask verbally, there's some questions in the Q&A section.
Okay.
So Vincent said, thank you for the presentation. My question is, what if the patient's condition prevents one from having patient be aligned straight? For example, spinal mets or patient has some wound or disease prevents the patient from laying in an anatomical position or prevents you from aligning the patient. Can one use the same position but use alignment marks both superiorly and inferiorly for the treatment?
No, we have, it depends, pre-simulation or post-simulation. If we have the problem of pre-simulation, so the patient can lay down, so we need to find out, like, they can we put them on something slanted, slope, some kind of device that, they can lay down. That's what we start. Even with the head and neck, once we get them down, like before we plan, this is like, they come and, be able to lay down simulation. That's why, as a therapist, physicist, as a oncologist, that we can, brainstorm how we're going to set up this patient. Then, based on that, nothing's going to change during the treatment. But during the treatment, let's say some change happened and you'll be able to lay down. Is that affecting the area? The laying down affected close to the ice, adaptive simulation before we treat them. We want to make sure that, because if something changed and they'll not be able to lay down, now they're not going to match onto it. Treatment plan is no longer valid because so maybe, they probably need a new simulation, or maybe we'll do adaptive sim and see if they still line up. So this pre or post, the pre, we need to brainstorm and how we're going to set them up first, right? We put them, can we change the setup? Can we put a thick pad instead of just a normal small pad for them to lay down? Okay, stuff. Can we open, like, let's say the lesions, are we be able to use the mask, open face mask? Can we cut the mask out? Or, that's what the brainstorming counts. This is before simulation, and it would be post simulation. If the nail it down on perfect, then you take the X-ray and the new simulation.
Zaka Khan asked, can delineation of some bony structures on a DRR make matching more quick?
Especially with the technology we have right now, even you'll be able to see clearly because the KV image we take nowadays, just like crisp. So it would help, for some people, like, but, I usually, take everything off, discount, so that's what I use, but it may help other people. So everybody have, different choice of aligning, may help for them, but for me, I prefer just going straight to the bony anatomy. There's no any contour or.
And this is our the last couple questions. Nicholas says, kindly revisit example 2 for head and neck. I missed the conclusion. Yeah, just wanted to hear the conclusion about example 2.
Okay.
For
so, like I said earlier, on this one, you see the space. This is perfect, beautiful. And that spinous process is good. Base of skull is good. You see, you see 2. Line up pretty good here. You look at it, okay, that looks good. As I say, look at the whole picture for the whole picture right now. That's what I'm saying here. Look at the chin right here. All right, now we come to the DRR. See how open that mouth is on the DRR versus it. You see, you can look at that, and so the conclusion is, the patient open the mouth.
Also for head and neck, someone asked, how do you fix open mouth issue on the patient? Then Zaka replied, you can minimize by using Bite-Block.
So, I mean, it should be a standard, to have a, especially if you're treating that high stuff, it should be a standard to use a Bite-Block. Bite-Block makes a big difference because, I mean, you could tell them to close their mouth, but, let's say the mouth, how about they forget? They fall asleep, you know what I'm saying? So, yeah, I mean, if you already sent, yeah, you want to make sure that, you take your X-ray and watch it, check that, look like the mouth is closed, I mean, we have to verify anyway, whether they have mouth block or not, we have to verify. So the best thing is, Bite-Block. The Bite-Block is going to do the job. Even sometimes you could use a cork and make, custom at the clinic, use cork, spray the cork, put some tongue blade, and let them bite it and create it right there. And so they have something to bite on. That's all the school stuff, before all this new stuff.
All right, that's all the questions in the Q&A. If anyone has an additional question, I see 2 people have their hands raised.
Okay.
Hello, sir.
Yes, sir.
For patient of head and neck cancer that come with a big wound on the head or on the neck, and the wound require dressing every other day, we fully that the thickness of the dressing or the planning, how do you does such patients require marks or not?
Okay, so one thing you can do is, see, for the head and neck, I mean, the best bet is to use, especially if you use an IMRT, if you're going that way, you gotta have mask. So another thing what you could do is, after you make the mask, you could, cut out that area. You know what I'm saying? But if the area that you're treating, you gotta be careful though, there's no motion, if it's the area you're treating. And sometimes, we could have like, if it's, let's say it was on the right side, you can set them up with the, lateral head holder. You can lay down in that area. I mean, everything is stayed, the mask is covering them in the lateral, in the area that, especially if it's the area lesion is too big, to be like that. But you know what? We make masks for patients, with the lesion. But you have to make sure that when you're making the mask, first of all, you don't want there's some kind of things bleeding and stuff like that. Make sure it doesn't stick when you make the mask, and put some make sure you put the mask, that hat, what all that before you make it. Be careful. But we'll be making masks. Be careful, when you make it. Have more than a couple of people to make the mask. So you do it slowly and smoothly, but if you'll be able to tolerate it, then they're not going to be in that mask. So maybe you need to have like open mask for that. If it's like in the face area and stuff like, they have like are we able to use open mask? Use an open mask, or do we need to cut it? So it depends, what kind of resource the clinic has. So that one is going to be like a brainstorming between the therapist, the doctor, once he's in. So that's going to be treatment for the patient. So we have to make sure that they be comfortable, they be able to tolerate this treatment for the next 30 days.